Hello, my name is James Gill, and this is the start of what will hopefully be a series of podcasts based around clinical examination skills. And this is brought to you in association with Titanium Health for all your locum needs. Right, that's out of the way. The whole idea for this came about because I was talking to some students about how they do revision and the like, and like myself, most revision and most learning is now done online or electronically in some form, and textbooks kind of don't get quite as much input as they used to. So this was an idea based upon that, to try and do a series of podcasts that can be used both in a video format, but also for just pure audio if you're going running, swimming, revising in the car, something like that. Trying to get the maximum utility out of these things. So to start off, today I'm going to go over the general examination. Personally, the general examination I don't like too much. It's a bit of an artificial idea. Nobody walks into a doctor's surgery and says, "Doctor, my general's a little bit off, could you examine it please?" But that said, it is a very useful tool to start off right at the beginning with. For medical students, in terms of understanding how to look at a patient and how to examine them, as much as it is for just starting to talk about vocabulary and understanding the simple process of the examination. So, to begin with, in terms of doing a general examination, we need to know generally how the patient is. So, with that, what is the normal vital signs that we'd see looking at a patient? So have a think to yourself, what are the normal values for a patient's temperature, their blood pressure, their pulse, their respiratory rate, and their oxygen saturations? What do you think? So let's start off at the top with temperature. What is a patient's normal temperature range? That should be between 36.5 degrees Celsius and 37.5 degrees Celsius. When a patient comes in to see me and they say they're feeling a bit hot, they think they've got a bug, when I check their temperature and I find that they've got a temperature of 37.3, 37.4, I will say to them, you've not actually got a temperature here at the minute, but given the history, I'm still going to say, you're definitely warm at the moment and, that's going to feel a little bit unpleasant. Probably, as you say, there's something going on. Let's look a little bit closer. So from there, we're going on to do a patient's blood pressure. At the bottom end of normal, we're going to have a patient with a systolic of 90 and a diastolic blood pressure of 60, absolutely. Then when we go higher up, our systolic at the top end of normal will be 120, and at the bottom end of, and at the top end, the diastolic will be 80. Okay, so looking at the pulse, what do we consider to be a tachycardia? So a high pulse rate. So that's anything over 99. So 100 is the tachycardic, and obviously 99 will be our normal point. Let's look at the bottom end. Where's bradycardia? So sometimes you'll see a bradycardia described as 50 beats per minute, but the bottom end of normal is 60 beats per minute. So what do you do about that middle ground? I think it's reasonable to consider anything above 51 beats per minute normal. Then going on to respiratory rate, this is very, very useful to get an overview of how the patient is. So at the top end of normal, we'd expect a patient to be getting no more than, say, 16 breaths per minute. And at the bottom end, they should be ticking along quite happily with 10 breaths per minute. Staying with the respiratory idea, what's normal for our saturations, the amount of oxygen we can get into the mouth, through the circulation and into the peripheries? We'd expect top end of normal being 99 or 100% because it shows everything's working fine, all the way down to a saturation of 92%. Now, I'm actually going to start paying a lot of attention when a patient's saturations hit 95. What's going on and why are they down at this level? However, we don't have to worry excessively until they get below 92. That patient's in trouble and we need to sort something out. So we've got a good idea of what's the vital statistics on a patient, and they're things that we we're going to want to know before we go any further. In terms of doing the general examination though, we ideally want to start off with the patient's hands, because there's a huge amount of information that we can see here. So in a moment, we're going to go through describing the things that we may see in a general examination. But to start any examination, we must begin it properly, and that involves what we might term wiping the patient. So welcoming the patient, introducing ourselves, giving patient consent or getting patient consent, and then explaining the procedure. Technically, you want to explain the procedure to get the consent, but wipe works as the acronym. So once we've got consent for the patient to be examined, I will normally comment as they move over to the examination couch. How are they walking when they get there? Are they sitting calmly at rest? Was it difficult for them to get on the couch? Similarly, have they any paraphernalia with them? Are they clutching an inhaler? Are they walking with their stick? How is their gait? All of these things are relevant to building that overall picture of the patient. But as I said, once we've got that overview, we're going to start off with the hands, and specifically the fingers to begin with. There's a lot of things that we can see in the fingers. So what is one of the commonest things that medical students love to talk about? Clubbing. Absolutely. So here we get these large spoon-shaped fingernails, bulbous, almost chicken drumstick style fingers. And we need to be able to prove that the patient has clubbing rather than just saying their fingers look a bit swollen. And the way we do that is we get the patient to put their fingertips together so that they're making a diamond shape between the fingers, and that's called Shamroth's sign and indicates that there is no clubbing if we've got that diamond shape there. Conversely, if we can't see it, then it says that there is clubbing. And a very common question at medical school is, what are the causes of clubbing? There's quite a lot of pathology or problems that can produce clubbing. However, there is also idiopathic, that this is just a thing for the patient that is normal for them. I've actually seen quite a few people who have familial clubbing, where the family is fit and well, but lots of members of the family have this swollen nails type appearance. We'll talk further in the next couple of podcasts about the different specific causes of clubbing when we're doing our systems reviews. But for the time being, it's worthwhile highlighting just the range of different causes of clubbing. So we can have cirrhosis of the liver, which would cause clubbing, inflammatory bowel disease, which can cause clubbing. You can have empyemas, so abscesses in the lung, bronchiectasis, so destruction of the alveoli. We can have problems with the heart, one of which being cyanotic congenital heart disease, where the vessels are placed the wrong way around, and you end up getting blue babies. As you see, there's a range of different systems that are affected, and as I say, we'll go over those in more specific detail later on. So we've covered the swelling of the fingers. What other changes can we see in the nail? Another classic one are splinter hemorrhages. So these are little black dots or lines that people can see in the fingertips. The biggest common cause that normally comes out of medical students' mouths is bacterial endocarditis, where you get an infection in the heart and you get bacteria forming lots of little leaflets on the valves which break off and speed through the vasculature to lodge in the capillaries in the fingers, but also the capillaries in end organs such as the liver, the brain and the lungs. So this sign suggests there may be more pathology going on that we can't see, because these little black bits, these lines that we see in the fingers, are when the bacteria lodge in the capillary, block it and cause an area of necrosis or cell death. That's what the blackness is. But a more common reason, and normally why I've got splinter hemorrhages most of the time, is because of mechanical trauma. In my case, usually because I've trapped my fingers with a spanner when I've been changing wheels on my bike. So that's the splinters. We can also get other deformities to the nails, so one of which being colonekia or spoon-shaped nails. Normally, we've got a nice concave shape, but with colonekia, we get a concave shape. Here, if you could test it by dropping some saline on the fingertip, and it would sit in this hollow. This is found in patients that have chronic iron deficiency anemia. Another deficiency is when we see leukonychia or white nails. This is seen in a low protein state. So maybe something like nephrotic syndrome, where you're losing a lot of protein continually for the body, would cause this problem. And when a lot of people see it for the first time or in pictures, it does look like somebody's put Tipp-Ex on the fingernails. You can get little white lines or white specks on the fingernails. This is not leukonychia due to low protein states, but this is normally due to simple trauma, where someone's banged their finger and caused a little bit of whitening there. Okay. Another change that we can see, we can get splitting of the fingernail or coming away from the nail bed. This is called onculolysis and can be seen, for example, in thyroid conditions and in various other skin conditions such as psoriasis, or again, like me, if you've fallen over and jammed something into your knee. I think we're seeing that I am a little bit accident prone, but we'll discuss a little bit more of that when we come to the orthopedic stuff. Okay, what else have we got with the fingers? Let's stay in a straight line or a simple line. So let's move from the fingers and let's go more proximally. You can get swelling at the distal and proximal interphalangeal joints if we've got osteoarthritis. So the two names here would be Bouchard's nodes at the middle joint and Hebridean's nodes at the end joint are distal and proximal. I've always liked to think that one way of looking at these simply is that our Hebridean nodes are like the Hebridean Isles in the UK. They're furthest away from the mainland, so they're the bits that are furthest away from the body. We can get swelling of the fingers and swelling of the metacarpal phalangeal joints. This is what's normally seen in rheumatoid arthritis and is a significant sign that we do need to act upon quickly in order to prevent any further damage occurring to these patients' fingers. If we turn the hand over and have a look at the palm, we might be able to see how quickly a patient's capillary refill is. So if we press the fingertip and release the pressure, the capillary refill is how long it takes the blood supply to return, so from going pale back to a normal pink. And we normally expect that to be about 1 second. If it's getting more sluggish, this might be due to a patient having cold hands or a slow volume output, so somebody perhaps having hypovolemia or a low blood pressure. Conversely, anything that is faster or an immediate refill shows we have a hyperdynamic or an increased circulation. So perhaps seen in infections, so sepsis, or in hyperthyroidism, for example. Another thing we can see with hyperthyroidism on the palm will be palmar erythema, so red palms. But that's not the only thing that can cause it. We can also get this red palm appearance in two other conditions. One being cirrhosis of the liver, so liver damage, and the other, pregnancy. Now these two conditions connect because they're both high estrogen states. When your liver gets damaged, you end up with high levels of estrogen because the liver can't break it down. And similarly, when you're pregnant, there are higher levels of estrogen supporting the pregnancy, and thus we get the palmar erythema. But note, it's not the estrogen that causes palmar erythema in hyperthyroidism. That is merely a hyperdynamic circulation, so we've got increased blood supply. Staying with the palm, we can get whitening of the palmar creases, which, like our colonychia, might indicate a patient being anemic. Now, who is the coolest actor that we have in the UK? Yes, you're right, it's Bill Nye. If you look at all of his films and in his pictures, he's always pulling very cool poses with his fingers. The reason for being that is he can't actually move his little and ring finger. He has something called Dupuytren's contracture, which is a thickening of the palmar fascia. Now, normally this will just be present as like a feeling of a cord or thickening under the skin. But as it worsens, this cord will contract down and will pull the outer two fingers down into position. Hopefully, we'll get a patient seen by the orthopaedic team before they get to any significant deformity, so we can release it and allow their fingers to go back to normal. This can be, like clubbing, can be familial due to bad luck, and there are some studies that suggest there is a connection with alcohol abuse as well. Carrying on, from the palms, the other thing that we may see here is a single palmar crease, such as in a patient with Down syndrome. Although, to be fair, there are a large number of other visual features that we're going to see that are going to indicate Down syndrome rather than just that single crease. Having looked at the hand, we need to move again closer at the body, so we're going to start off doing the radial pulse. The easiest way to find your radial pulse is find your radial styloid, so the knobbly bit at the base of your thumb. Put 2 fingers here and just let it slip down into the hollow beneath it. From here, you should be able to feel the beat of your pulse. When we're talking about a peripheral pulse, like the radial pulse, we can get 2 bits of information. What is the patient's pulse rate? So, is it 60 beats per minute? And what is the rhythm? So, is it normal sinus rhythm? So, regular, 1, 2, 1, 2. Or is that an arrhythmia? So, an abnormal rhythm. For example, you could have a regularly irregular arrhythmia. So 1, 2, 3, 1, 2, 3, 1, 2, 3. We could also get an irregular arrhythmia. So 1, 2, 3, 1, 2, 1, 2, 1, 2, 1, 2, 3, 4, 1, 1, 2, bouncing all over the place, which is seen in atrial fibrillation, which, like clubbing, has a large number of causative factors which can bring on this abnormal pulse. Moving further up to the arm, the brachial pulse, here it's worthwhile checking, or the carotid as well, because we get an additional piece of information from the pulse, the character. So that's how forceful or strong the pulse is. Is it weak and thready? If we've got a patient who is shut down, they've got low blood pressure, maybe they're septic. Or is it a hyperdynamic circulation? Is it bounding, a very forceful pulse? Has this patient got high blood pressure? Are they affected by hypothyroidism? Is the pulse cranked up to 10? At this point in our examination, we also want to do the blood pressure, taking it from the brachial pulse here. Carrying on up, we want to have a look over the face. So we can start off looking at the patient's eyes. Do they look nice and white, the sclera of the eyes, or is it yellow? Is it jaundiced, which might indicate a hematological or a blood problem, or more likely a problem with the liver, both of which resulting in higher levels of bilirubin in the system. From there, we can actually have a look at the iris, so the coloured part around the pupil. Is there a white arc around this called corneal arcus? This is normally due to high levels of cholesterol in the blood, and is seen in people as they get older a little bit as well. If there's that high level of cholesterol, we might see around the eyes yellow deposits of cholesterol called xanthelasma. We may have noticed those further up earlier on in the body, where we can get yellow patches on the tendons, again cholesterol deposits called tendon xanthoma. We would then want to get the patient to pull their eyelids down, and we can have a look in the conjunctiva underneath the eyelid to see if it's pale, suggesting they might be anemic, which would go along with our pale palmar creases and potentially cholonychia. Or we may have signs of infection there, so very red and possibly sticky discharge at that point. Carrying on down the face, we want to have a look at the mouth. So having a look at the lips, are we getting any evidence of central cyanosis? So we can have 2 types of cyanosis. Peripheral cyanosis, where we may get blue fingertips, which could be due to cold, and the blood vessels are simply shutting down and not letting new blood get to the fingers. Or is it something connected with the heart or the lungs, in which case we'll get our central cyanosis, where we get a blue tinge to the lips. This is a very worrying sign, suggesting, as mentioned, that there is quite a significant problem in the cardiovascular system. We can also confirm this by having a look under the tongue, which might show us again blue blood vessels under there. Whilst we're looking inside the mouth, we may find evidence of poor dentition, which can be associated with patients that have poor cardiovascular outcomes. However, it's important to highlight that this doesn't seem to be causative, i.e. bad teeth cause problems with your heart, but it's more an association that people who have poor dentition may have a lifestyle which has resulted in large numbers of cardiovascular risk factors. Staying with the tongue, we can see other things which might suggest an anemia. We might get a pale tongue. So there we've got our pale palmar creases, our colonekia, our pale conjunctiva and our pale tongue, all suggesting an anemic patient. But we might get a big, red, beefy tongue and it's become smooth and lost the papillae on it. That would indicate a vitamin B12 deficiency. And if we're getting changes like that, we might actually see a different type of anemia, a macrocytic anemia, where we get large blood cells, as opposed to the iron deficiency anemia, where we get small blood cells. Staying with the mouth, if we've got vitamin B12 deficiency, we may also see angular stomatitis, so cracked sores at the edges of the mouth. But note, this is different from the common cold sore, where because that's a viral infection, we also get vesicles, so little tiny fluid-filled blisters associated with the viral infection that we don't get with the angular stomatitis from vitamin B12. Carrying on down, we want to have a look at the patient's neck, and it can be useful to do that from the side to see if there's any goiter or swelling there, which might be associated with a thyroid problem. We would also want to check over the neck and around the head to see what is present with regard to lymph nodes. The lymph nodes are essentially the barracks for the immune system. If you, for example, get a sore throat, the white blood cells are going to have to move to this area in order to fight whatever's causing your infection, and thus we'll get these swellings occurring in the neck. Most patients will come in and say that their glands are swollen. What their meaning is that they have lymphadenopathy. We'll want to check on the superficial and deep cervical chains positioned near the large muscles of the neck, the sternocleidomastoid muscles. Going up from there, I like to check along the tonsillar lymph nodes and then along the submandibular lymph nodes. You can actually press quite far inside your jaw without causing any discomfort to find these lymph nodes. And these lymph nodes are normally enlarged if we have problems with dentition, such as an abscess affecting the teeth. Now, at the very front of the jaw, we have our submental lymph nodes, which drain from the tongue, and their enlargement can indicate significant pathology there, such as maybe cancers or, again, damage and infections. Moving upwards, we're going to look at pre- and post-auricular lymph nodes, so lymph nodes in front and behind of the ear, before we finally finish off at the back of the skull with our occipital lymph nodes. So that completes our head and neck lymph nodes. There is another set of lymph nodes which is very important. This is the supraclavicular lymph nodes. We get our patient to shrug their arms and shoulders up and forwards so you can push your fingers deep into the supraclavicular fossa there and to see if there is any swelling there. This is very important because on the left side there is a lymph node there called Virchow's node, which becomes enlarged if we have problems with the lungs, or the pancreas, or the stomach, and it is a very significant sign of poor pathology, potentially lung cancer, for example. Having completed this, when we do the general examination, it's normally worthwhile to have your patient exposed at the chest, and we may see if there's any signs on the chest related to something like spider nevi, which are wonderful. Well, I say they're wonderful. I like them because they're little star-shaped blood vessels that when you press the center of them, they will disappear. And when you remove your finger, they refill from the center outwards. Now, they're not unusual in normal people. So we do need to look at the front and the back of the chest. And we can have up to 10 being considered to be normal. That's quite important because they're also seen in pregnancy, connected to that high levels of estrogen. And that indicates what can be our pathological cause of that. If we've got liver failure or anything else causing high levels of estrogen, then we'll probably get more than our 10 spider nevi present. The last bit that we would need to do with our general examination is check for peripheral edema. That's done down at the ankle normally, and you want to press in at the medial or inside part of the ankle on the tibia with 10 millimeters of mercury. That will be enough to turn the fingertips of your fingers white, and will be enough to displace any fluid from inside the tissues outside, leaving an indent which you'd then be able to feel with your fingers. We'd complete our examination by reviewing any bloods that the patient might have, checking again any drugs that they might have brought with them, and thanking our patient for their time today. So that would complete our overall general examination. As you can see, it's about looking at the patient as an overall, rather than examining one specific symptom, one specific system, which we'll do over the next few podcasts instead. So I'll be very interested to know your feedback on this as it's the first try. Do you think this has been worthwhile? Is it something that you would want to listen to again? Or crucially, are there things that you'd want to change? Ultimately, this is about creating a potential revision resource. If there are things that will be better, then please drop them in the comments below, and I'll see if I can incorporate those into further podcasts.